everybody. Welcome to OsteoBites. Thank you so much for joining us today. I will just give a couple of seconds for everyone to get settled into our virtual room. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Joanne Tuohy, who will be sharing information about canine trials studying histotripsy as a novel tumor ablation modality for treating osteosarcoma. Thanks so much, Dr. Tuohy, for joining us today. We are thrilled to have you. We are also very excited to have our panelist Walker joining us today. Everyone, please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Tuohy after her presentation. A little bit more about our guest today before we get started. Dr. Joanne Tuohy is an associate professor of surgical oncology at the Animal Cancer Care and Research Center at Virginia Tech. Her research focuses on developing a novel tumor ablation technique, histotripsy, as a non-invasive method of tumor elimination and as an immunomodulatory therapy that can induce synergism with immunotherapies. Dr. Tuohy has focused her work primarily in osteosarcoma to improve treatments and disease outcomes for patients. Her tumor ablation research is also expanding to include other tumor types such as oral tumors. Dr. Tuohy went to Colorado State University for her DVM education. She went somewhere else for her DMV, followed by a rotating internship and surgical residency at North Carolina State University. She also completed a comparative biomedical sciences PhD program in immunology at North Carolina State University, completing her training as a fellow in surgical oncology at Colorado State University. Dr. Tuohy started her faculty career at Virginia Tech in 2019 and is a member of the Animal Cancer Care and Research Center at Virginia Tech. The center offers comprehensive cancer care to veterinary patients and hosts veterinary clinical trials for dogs and cats with cancer. Thank you so much for joining us today, Dr. Tuohy. We are very much looking forward to your talk. Before we get into your presentation, we have a few announcements, and bear with me, we actually have a lot going on. But lots of kind of exciting news. So first of all, our 2025 Outsmarting Osteosarcoma Research Grant, a letter of intent submission period closes tomorrow, October 25th at 11:59 p.m. Eastern. So if you're considering, you still have 24 hours to apply. I'm going to put a link in the chat to find more information, the eligibility criteria, program guidelines, what's required for the LOI, and also access to the Proposal Central link. And also save the date. Factor 2025 is going to be June 26th to 28th at the Grand America Hotel in Salt Lake City. Registration will open probably early February, but abstract submission is now open, and the submission deadline is January 10th. So you have a bit of time to think about that, but just want to get it on everyone's radar. Also, so you can just mark the dates in your calendar. Dr. Tuohy has attended Factor and presented also at Factor past couple of years, and we usually have a great comparative oncology cohort there in attendance. Another thing that's happening in November is we have our next Turbo meeting. So clinicians and researchers with an interest in osteosarcoma are invited to join Turbo, which is our virtual tumor review board for osteosarcoma. It's an educational forum where clinicians discuss complex cases. And it can also be a great way for researchers who don't normally see patients to learn more about real world clinical challenges and treatment challenges. It is open to medical professionals only, but if you are a patient, you're welcome to ask your oncologist to present a case on your behalf at our upcoming meeting. And our next meeting is November 6th at 5 Eastern. And so interested in presenting a case, or if you just want to attend, you can email me at christina@mibagents.org. And whenever we have an episode featuring work on canine osteosarcoma, I'd like to highlight our canine clinical trials resource on our website. It provides information and resources about participating in canine clinical trials, as well as a directory of veterinary oncology programs and open canine osteosarcoma trials, including a study on histotripsy that Dr. Tuohy will be discussing today. Plus, there's another trial as well open at her institution. So I'm going to put a link into the chat with direct links to those, and you can find more information there. We also have a comparative oncology playlist on our MIB Agents YouTube channel. I'm going to put a link into the chat on there. And I know it's been a lot, but I'm going to wrap it up now with November is Pet Cancer Awareness Month. And so we're going to be back with our Out Barking Osteosarcoma fundraiser. You can order a fashion statement bandana for your doggy. You can snap a photo of your doggy rocking the bandana. And then you'll have an opportunity to share their story and encourage your friends and family to vote for our Who Wore It Best contest. So stay tuned for our photo contest registration details. But in the meantime, you can get ready and order your doggy bandana. So I'll put a link in the chat with more info on that. All right, that is it from me, but a lot going on the next couple of months. Walker, could you please introduce yourself?
Yeah, hi, my name is Walker. I'm part of this year's junior advisory board and have been for the last few years. I got the chance, or I got a sneak peek of the slides today and got to learn a little bit about histotripsy, but I'm really excited to learn more and get the expert explanation from that. So you can take it from there, Dr. Tuohy.
Great. Thank you so much, Walker. And thank you so much, Christina, for your kind invitation to share some of the work that we're doing with Histotripsy and osteosarcoma. So thank you. Let me share my slides. All right. Okay. Is the slide showing okay?
Yep, that looks perfect.
Great. Thank you. All right. So again, thank you for the opportunity to chat to you guys about the ablative and immunomodulatory effects of what we have observed thus far with Histotripsy treatment in osteosarcoma. And as Christina so kindly pointed out, I am part of the oncology team, the veterinary oncology team at the Animal Cancer Care and Research Center at Virginia Tech, and we're located in Roanoke, Virginia. But we also have a main campus in Blacksburg, where actually a lot of the clinical trial treatments happen. So let me just start off. It's probably not a new topic to those on the call, but just to highlight the strengths of the dog as a comparative oncology model, research model to help inform our findings that can benefit both dogs and people at the same time, those of the patients with osteosarcoma. And so with the dog as a comparative osteosarcoma model, there are just overwhelming similarities between the dog and the human patient with osteosarcoma. So we've got biologic behavior that's really similar. So for example, the anatomic locations at which these tumors arise. So in the appendicular skeleton of dog and people, and also the way that the disease metastasizes, the responses of the disease to various treatment options, which are also share similarities between dogs and people. And under the microscope, the osteosarcoma cells between a canine and a human sample virtually look the same. And they also share some gene expression. And the dog uniquely as a pet, and a pet who shares our household, then also shares our environment. So you can see my dog and my spouse sharing a very intimate nap in the afternoon on a weekend. And so they share what we're exposed to, all the environmental pollutants, the chemicals, dust, food. And so they do that, and that is a big contrast with, say, laboratory bred rodents who have a lot of contributions to research, but they also live in a very controlled environment. And so that's a major difference that the dog has to offer, and also the anatomic size. So a lot of dogs, especially dogs that are affected by osteosarcoma, are large and giant breed dogs. And many of our giant breed patients, they are very similar to us in size, perhaps not in anatomic makeup as much because they do ambulate with 4 limbs instead of 2, but a lot of our canine giant breed patients, they easily outweigh me. And so for device development, that provides an advantage because we are testing the devices that are going to be used in people instead of having to make the devices a lot smaller to accommodate device testing in, say, mice or rats. And so that really offers a good advantage for us with our canine models. And sadly, dogs have a much higher incidence of osteosarcoma than we see in people. And this increased incidence plus their shorter expected lifespan compared to us as people allows for them to offer information and data from, say, clinical trials that will be available a lot more quickly versus a clinical trial in people. So most of the giant and large breed dogs, their life expectancy, their natural life expectancy is about, say, 9 years to 12 years on average. And so when we have a dog who is suffering from osteosarcoma, with treatment, their expected survival is a lot shorter than for a person, than for a human patient. And so within a year, we can typically gather quite a lot of data from our canine patients who participate. So those are the various strengths of why we carry out studies in our dogs, and these are pets, so they come from families, they're much loved, and so everyone on the team here, we're very appreciative of the people who take the time and effort to come and participate with their dogs. So histotripsy, let me just introduce that concept. It's a unique focused ultrasound ablation technique that relies on non-thermal ablation to destroy basically cells in its focus. It doesn't have to be cancer cells, but it is very prevalent. The research is prevalent for histotripsy ablation of various cancers. And actually very recently, it's been FDA approved for use in people with liver cancer after a very rapid kind of progression and advancement of the research that started with histotripsy, and it started with liver tumors. And so we're trying to expand that to include ablation of other tumors, including osteosarcoma. So what does it do? So by its name, intrinsically, histo in Greek means tissue, refers to tissue, and then tripsy refers to the breakdown of tissue. So what histotripsy does is that it breaks down tissue by creating these bubbles in the tissue. So when the ultrasound wave is transmitted to a focal point in the tissue, it creates these microbubbles that then coalesce and they start to expand and shrink and expand and shrink. And ultimately, they create enough stress and tension that they disintegrate and that leads to the disintegration of the tissue that is in that focus as well into subcellular components. So it relies purely on mechanical energy to break down the cellular structures. So in this image here, it's an ultrasound image. And in this circle here, this very bright area on the ultrasound is the cavitation cloud. So the cloud of microbubbles that forms as a result of the delivery of the ultrasound waves. And these are very high intensity ultrasound waves. And so when we're able to visualize a cavitation cloud like that, it allows us also the advantage of monitoring the treatment in real time as it's occurring in a patient. And so as we are able to do that in other softer tissue tumors, we have encountered, just as a little bit of information about the research that we've been doing, what we find is that for bone tumors, that bubble cloud is actually, or cavitation cloud is actually difficult to visualize because of the shadowing, the blockage of the ultrasound wave that is the diagnostic ultrasound wave that is stopped by bone. So just to clarify, the ultrasound waves that are creating this image is just a regular diagnostic ultrasound, and it's different from the actual high intensity ultrasound waves that are generated by the histotripsy transducer. So even though we can't see it with our imaging ultrasound probe, it doesn't mean that it's not present. But that creates an additional challenge for us as we develop histotripsy for osteosarcoma treatment. So I'll take you through a little bit of the work that we've done to develop pretty much from scratch what we can do with histotripsy and osteosarcoma. And our hope is that we can achieve a non-invasive way to ablate these osteosarcoma tumors and also achieve a degree of immunomodulation. And in previous preclinical studies by other groups and by us, we have found that histotripsy could create or activate an immune response in other tumor types, for example, in liver tumors, in people, and in the preclinical studies as well. And so that kind of immunomodulation would have potential to attenuate the potential for metastasis development and also create synergism with other adjunctive immunotherapies. And that has been shown in preclinical studies. And of course, the important thing now is, can we actually carry that and realize that in the clinic? And so those are the two major goals we have as we started to develop our work with histotripsy ablation for osteosarcoma. So we started kind of early with some ex vivo studies where we took excised canine osteosarcoma tissue, and you can see, if you can see my cursor, this is a piece of osteosarcoma tumor is embedded in degas gel. This is the histotripsy transducer that is then ablating the tissue ex vivo. And so we ablated tumor, and we also ablated normal bone and nerve because we wanted to investigate whether the doses that are required for ablating for ablating osteosarcoma successfully with histotripsy would be detrimental to normal structures that may be in the field. And so we did that, and we were very pleased to find that, yes, histotripsy was very effective in ablating, say, a piece of tissue, as you can see in A. Sorry, my cursor is right there. So a piece of tumor tissue, and in D here, it's outlining in the red box that bubble cloud, the acoustic bubble that we can see. And the reason it's so clear here is because this is literally a piece of kind of tissue, soft tissue portion of the tumor. So it doesn't have that piece of cortical bone that blocks the imaging. And so then in B and in C, we see that these are slides, so histopathological slides with H&E staining of the samples that were obtained. So B and C represent untreated sample. So we can see there's osteoid, which is outlined as the pink matrix here, which is very much a prevalent feature in osteosarcoma histopathologically. And then this is low magnification, and it's hard to see the individual cells, but all these purple dots here represent live or at that time viable tumor cells. And this is a high mag image of the tumor cells that are present. Then after ablation, we see in E and F, so low mag in E, high mag in F, that we essentially see kind of a sea of purple and not really any viable cells that can be noted. So we were very pleased and encouraged by those results. And those results also informed us that the doses used to treat the osteosarcoma tumor were not going to injure normal tissue. So the normal normal bone, normal nerve that we had ablated, they histologically looked the same essentially as unablated bone and nerve. So that was all very encouraging. So we also started some preclinical studies where we wanted to understand the immune cell responses to histotripsy ablation of osteosarcoma. So we have in the setup here, A is our histotripsy setup for ablating cells, ex vivo or in vitro, and also for ablating actually our murine models of osteosarcoma. So we have the little transducer here that is in a tank of degassed water, and then the cells, as you can see, are suspended here in a cell suspension. And this little laser beam helps us identify where that histotripsy ablation cloud ends up in that tube of cell. It can identify the bubble cloud that forms. And so we see here in D that we have, after ablation, that we have the majority of these cells are dead with some cellular debris. There might be some live cells because the intention was to ablate, in this particular experiment, 95% of the cells and leaving about 5% of viable cells for evaluation. And what we did was first we demonstrated that the cells that were ablated were non-viable, as you saw in that image in the prior slide, but then also the cells that remained. And you see the groups here, the black bar would be the ablated cells, histotripsy ablated. And then this middle bar here that's a lighter shade of gray is the sham treated. So these are cells that underwent the whole procedure of getting submerged in that tube in a cell suspension, except the histotripsy delivery was never, the histotripsy was never delivered. And then, of course, untreated tumor cells. And these are D17 canine osteosarcoma cells, D418 and Abrams. So 3 different cell lines that we conducted these studies in. And we saw that after the 2 divisions, cell divisions in general, we started to see a spike in the growth of these cells that were sham treated and untreated. So these bars here, they started to proliferate, and then the ablated cells had some degree of proliferation, but then by division 4, it was starting, they then started to be non-viable. And so did not ultimately survive, even though they showed signs that they were trying to divide. And that was important information for us because we realized that clinically, when we're performing tumor ablation, it's unlike a surgical resection where I can rely on my pathologist to tell me what's happening to my surgical margins, whether I've achieved complete margins. And so when I would like, the whole research team would like to know what happens to, say, potentially unablated cells or cells that are not completely ablated, because I think that's important for eventual clinical relevance. And then we examined the cell death signatures because one of our hypotheses is that we can initiate immunogenic cell death with histotripsy, as was shown in other tumor types. We wanted to explore this in canine osteosarcoma. And so by exploring the different gene pathways of cell death, we found that with, for example, this is just to show the D17 cell line had an upregulation of some of these pathways that are strongly associated, like necroptosis, apoptosis, with immunogenic cell death. And I just want to make sure I give credit to my amazing postdoc who works with me, Dr. Elena Hay. She did a lot of this work and published on it. So then we also conducted co-culture experiments in vitro. So this is unpublished data. So just for everyone's information, the slides that contain unpublished data will be omitted from the recording. So just to explain that. And so these canine monocytes were primary monocytes, and they were cultured with osteosarcoma cells, these 17 cells that were either untreated, so just naive osteosarcoma cells, or they were sham treated or histotripsy ablated. And so there are some suggestions of an inflammatory type response in these monocytes, where we have upregulation of CD80, which is an inflammatory marker, and also upregulated secretion of one of the inflammatory cytokines, IL-8. And again, these are unpublished data, so the slide will be omitted. So there was also a similar experiment that was a co-culture experiment carried out with canine macrophages. And again, these are macrophages that were exposed to the different experimental groups, as I outlined in the previous slide. And we found in general that, again, there was an upregulation of the inflammatory marker CD80 expression in the macrophages, and a downregulation of reduced secretion of TGF-beta, which can be immunosuppressive and can be used by various cancers to suppress an immune response, and also an upregulation of an inflammatory cytokine, GM-CSF. And so these data, although in vitro and preclinical, were interesting and are suggestive to us that it's worth exploring the immunomodulatory response in osteosarcoma with histotripsy ablation. So we also utilize our murine models of tumor. So here it's that same setup that you saw in the previous slide, where we've got the transducer, an 8-element transducer, and then we've got our murine subjects with their osteosarcoma tumors that are receiving histotripsy treatment. And what we saw was promising in terms of the ablation that we can achieve. So we have slides here. The top row is untreated tumor, and then the bottom row is treated tumor. And we see that in the untreated tumors, which is not an uncommon finding in osteosarcoma, we have small areas of necrosis, tumor necrosis that naturally occur in these tumors. And so in the treated tumor, you see an area of necrosis that is ablation induced. And then when you compare the two areas of necrosis, so in the top row here, you see this area of necrosis in the tumor that's just inherently present in the tumor, where there isn't a lot of cellular infiltrate into that area of necrosis, versus in this F and G slides, where we see these very cellular infiltration of these areas of ablation, and therefore areas of necrosis. And these are immune infiltrates that are quantified by our pathologist collaborator. And we see that with histotripsy, there is expectedly an increase in the necrosis that occurs within the tumor. And also there is an increase in the inflammatory cell infiltration into the ablation zone. So again, very promising suggestion of an immune upregulation after histotripsy ablation of these osteosarcoma tumors. So I'll introduce you briefly to some of our canine clinical trials that we then opened as a result of some of these very promising results that we saw, especially with the ablative ability of histotripsy. So we initially enrolled patients in clinical trials where they underwent ablation of part of their tumor, but these families have already opted for standard surgical removal of the tumor. And in dogs, this usually comes in the form of limb amputations. And these dogs then went on to receive adjuvant chemotherapy, as is standard. And then throughout the time period of the study, we collected blood samples, we examined the ablated tumor, and these amputation surgeries were carried out at different time points. So 1, 3, and 5 days after the Histotripsy ablation. We wanted to examine whether that response of especially of the immune cells changes over time. And so this is just an image of the Histotripsy setup. This is a canine patient under anesthesia. This is the Histotripsy transducer, and this is a bowl of degassed water. And so this is what I was talking about in that earlier slide. This is that imaging transducer. So it's just a regular ultrasound imaging transducer. So these elements right here, those are the elements that are actually delivering the Histotripsy focused ultrasound waves. So that's how we can image and still deliver at the same focus ultrasound at the same time. So what we saw was promising, and in these early studies where we only ablated a portion of tumor, so we had another portion that's unablated to compare, and we saw marked hemorrhage, for example, in the areas that were ablated grossly, and microscopically we saw treated tumor had a lot of viable cells, and untreated tumor, and then treated tumor on the right side here had really no viable tumor cells, the red blood cells, and evidence of necrosis. And so that was all very encouraging. And we also then had carried out some evaluations on the peripheral blood immune cells. And again, these data are not published, so this slide will be omitted from the recording. So these are canine monocytes taken from the patients that were enrolled. And these, for example, are the 5-day post-Histotripsy treatment group, where we saw that 5 days after Histotripsy and 2 weeks after the Histotripsy and then subsequent surgery, we saw that there was an upregulation of CD62L monocytes, indicating a degree of activation, and also, even though not statistically significant, an upregulation of the CD80 inflammatory monocytes in the peripheral blood of these patients. And we carried out similarly as we did previously in our in vitro studies, where we tried to elucidate the canine immunogenic cell death signatures, gene signatures of these tumor samples that were treated. And they were treated samples that were compared to untreated samples. And again, this is unpublished data and will be omitted from the recording. So we've got these pathways of immunogenic cell death, so apoptosis, necrosis, these were upregulated. And so again, suggestive that in these treated Histotripsy treated portions of tumor, we have and a potential upregulation of immunogenic cell death. And then with the tumor samples that we obtained, we also carried out nanostring analysis, gene analysis, which allows us to analyze 800 genes that are related to responses to, say, immunotherapy or immune-based therapies or cancer therapies in dogs. And these are canine-specific assays, and these data are unpublished. And so this slide and the following slide, I'll show you these tumor samples that were 1 day, 3 day, and 5 day post. And for the green bars, they represent the untreated portions of sample, and then the orange bars are the treated, and then the naive purple bars are actually just osteosarcoma tumors that are from dogs that weren't part of a Histotripsy treatment clinical trial. They had their owners had just consented for us to use their tumor tissue after surgery for these studies. And so we see that there is initially 1 day post for the treated group, they do tend to cluster over on this side of the plot. And then over when we get to 3 days post, we kind of get a more upregulated signature of these immune cells or the gene signatures of the immune cells, especially within the treatment groups here, because when we have higher intensity, we have more of the orange/brown color versus the blue, which is the low intensity. And so we see kind of an aggregation of these treated tumor gene signatures that are more upregulated insofar as the intratumoral immune cells are concerned. So over time, we also seem to get this upregulation of immune cell signature when previously it may have been more quiet. And especially in the naive tumors, when we compare that, they tend to also have a more quiescent immune cell gene signature. So these data, we're very encouraged by that, and we're continuing our studies to really understand better the immune responses to histotripsy ablation. And so currently, we have managed to advance to canine clinical trials where we're able to offer a couple of at least 2 major trials for histotripsy treatment. One would be a trial where the families have already elected for limb amputation, and so they receive histotripsy treatment. And the difference in these trials now is that we're adding an immune stimulant to be injected into the tumor after the final histotripsy treatment that occurs. And then these dogs, if they're in this particular trial, will undergo standard limb amputation that was already elected by their families. And then for the other arm of the trial or the other clinical trial, we have families who have declined all standard of care, and that makes them eligible for this trial where we do not perform a limb amputation for the patients after histotripsy ablation and immune stimulant injection. And so we analyze their functional outcomes over time with gait analysis. So we have our patients walk over this gait mat so that we can measure how much force they might be placing on their affected limb after histotripsy, because pain relief is a very important clinical attribute that we have to pay attention to, because if an ablation technique does not relieve the pain from osteosarcoma, then essentially, in my mind, it's not a viable treatment modality. So we evaluate their gait. We also evaluate their tumors via MRI, our MRI, and then at the time of euthanasia, as is elected by their families, then they donate the limb from the dog, and then we examine the ablation zone histologically. And so just to show you some, these studies are ongoing. So again, it's unpublished data, and I just wanted to show you some of the findings that we have thus far. So when we monitor these ablations over time with histotripsy using MRI, we see that this was pre-treatment. This is the tumor here in the limb of a giant breed dog. And then after the first histotripsy treatment, we see there is a hypointense area in the MRI scan denoting an ablation zone. And then as we conduct our fractionated or sequential histotripsy treatments, after we complete the histotripsy treatments, and so 26 days post after the first treatment, we see that there is a nice area of ablation as represented by the hypointense regions. And we had previously conducted studies to correlate these MRI findings to histologic findings to ensure that they do indeed correlate to areas of cell death and necrosis when we see these hypointense areas on the MRI. So I wanted to just conclude by showing you a video. As I mentioned a couple of slides ago, the evaluation of pain is really important in these patients. And so I'll show you a video from one of our patients. His family, they've given consent for the video. And so you'll see this dog walking along. This was pre-Histotripsy. This was how he came to us. He was painful. He did not bear weight on that affected limb, the left hind limb. As you can see, he's hopping along. And this is the same dog after he completed the Histotripsy treatment. And this is what we're seeing. And so we were extremely pleased with some of these early results that we're seeing. Of course, there is a variation in patient response, but we are encouraged. So what we have currently that we're really excited about are further work that we are conducting at the moment. So combination therapies, that immune stimulant that I mentioned in our clinical trial that we have currently is actually N-dihydrogalactocitizine. So it is a compound that is currently in human clinical trials for breast cancer, for example, and it's an immune stimulant. It's a local immune stimulant that's injected into a tumor after, say, ablative treatments of the tumor. And so in people and in preclinical studies, that's laser ablation has been evaluated, and also HIFU previously in some of the preclinical work. So when this N-dihydrogalactocitizine was injected, it was found, the investigators found that it did upregulate immune cells and upregulate the infiltration of these immune cells into the tumor. And that also seemed to create a systemic immune response that was anti-tumor. And so based on those exciting results, we decided to try that for osteosarcoma and in the context of Histotripsy treatment. So that's what our canine clinical trials are focused on right now, is the addition also of this immune stimulant. Then we have some preclinical studies using murine models where we're combining checkpoint inhibitors, so anti-CTLA-4, for example, to our histotripsy ablation of osteosarcoma and assessing outcomes of that. And importantly, we are assessing the biomechanical integrity of these ablated bones, because the tumor unfortunately weakens the biomechanical strength of any bone. And it's important to evaluate whether histotripsy treatment further weakens the biomechanical strength of that bone. And that has important clinical implications, and also helps to provide the foundation data for our upcoming work, where we are wanting to investigate some bone support or replacement techniques into the ablation zone to help strengthen it. And this image is of the Illumina system that is in use for people for various indications, metastatic bone tumor treatment, for example, and also some selected fractures. And so we are in conversations about starting a study to try to evaluate the potential advantage of a bone support system like the Illuminos, and also advancing our Histotripsy device, where we are wanting to be able to customize the Histotripsy delivery to various portions of the tumor, because these osteosarcoma tumors are very heterogeneous. We may have some portions that are very soft, some portions that are very stiff, quote unquote, have stiff tissues. And so being able to have a more tailored ablation for that would be really, really helpful. And so those device developments are currently underway, and we're very fortunate to have a generous support in terms of grant funding for that. So thank you all for listening about these studies that are ongoing. I couldn't do it without my amazing lab group and also my very wonderful collaborator, Eli Vlasavovich, who is one of the developers of Histotripsy ablation when it first started at University of Michigan. And these are some of the very kind and generous donors and also supporters of the work.
Fantastic. Thank you so much, Dr. Tuohy.
Thank you.
Great prezzo. And everyone, if you have any questions, please feel free to add those to the Q&A in Zoom, and we will pick those up and ask Dr. Tuohy. But I actually have so many questions, so interesting. I wanted to maybe start first with, if you could speak a little bit, you just kind of alluded to this when you were talking about being able to tailor ablation to different parts of the tumor. But if you could talk a little bit more about differences in like tissue susceptibility to histotripsy, both in the context of even like tumor tissue versus normal tissue, because I think early on you mentioned that some of the normal bone nerves were not damaged at doses that were used to treat osteo. So like, I guess kind of part A of the question is, you know, what makes the osteocells kind of more susceptible to histotripsy where it's not damaging the normal tissue. And then within the tumor, just there, as you mentioned, there are differences in the tissue type, whether it's more like the soft tissue or like the bony. And if you can maybe talk about that a little bit.
Yeah, absolutely. Thank you. So the work that was done previously on histotripsy in its early development, and that is work that is done by my collaborator, Dr. Vlasavovich, they had elucidated that different tissue stiffnesses in the biomechanical engineering sense. So whether it's stiffer tissues versus a very soft tissue, they all have different ablation thresholds, i.e., it takes different amounts of energy to be able to start to generate that microbubble or acoustic cavitation cloud. And so as a result, that lends histotripsy the ability to be very specific to the tissue that it's ablating, even though there might be other tissues in the field of ablation. So what some of the early studies found was, for example, in the liver, where there are a lot of blood vessels. And so the question naturally would be asked, well, what happens to these blood vessels? We don't want to injure them. And what the group at Michigan had found was that, and others, they found that the stiffness of, say, a vessel wall was different enough that it did not, the threshold that it took to ablate, say, the liver tumor, did not reach the threshold of the vascular wall. And so that's how they could preserve that vascular wall and the vessel itself so that they didn't traumatize the vessel during these liver tumor ablations. So similarly, when we were ablating, and we're still carrying out some of these studies in normal tissue where we are ablating these histotripsy, these osteosarcoma tumors with histotripsy. So far, the threshold that's required, the ablation threshold that's required, does not seem to reach what is required to injure these normal tissues. So, i.e., the tissues that we're most interested in are bone, nerve, and also tendon, because they could be in the ablation field. And so actually our current studies are focused on trying to find what that threshold might be before we actually start damaging these normal tissues. And what we're finding so far is that we haven't quite reached them yet, and we're so far out of the clinical applicability zone of the threshold for ablating osteosarcoma that we're so far we're very encouraged that there is a big difference in that threshold, which then allows us to preserve these structures. But then at the same time, to your other part of your question about the heterogeneity of the physical attributes of the tumor itself, where it's some parts are soft, some parts it's hard. So that is where we're hoping to develop the device. And by we, I would say my brilliant bioengineering colleagues, I do not have that skill set, but they were collaborating with the University of Michigan, for example, to try to refine the transducer so that it could, say, detect a certain tissue stiffness, so to speak, in a certain part of tumor, and then be able to customize the ablation threshold or the ablation dose based on that feedback of how stiff or soft that tissue is within that region that we're wanting it to ablate. And so we can utilize the threshold differences not only to preserve normal structures, but also to try to customize the treatment within the actual tumor itself, so that we can, with one dose, yes, we can ablate the tumor and pulverize it, but it would be really helpful if perhaps we are able to tailor that so that we can perhaps increase the efficiency of our ablations, because the stiffer tissues like bone, they do require higher intensities, and so often their treatments may take longer. And so if we can shorten the treatment time in the areas where the tumor is softer, then we could also then increase treatment efficiency.
Kind of rolling off of that, are there any side effects? Like could a patient come in and get ablations one day and then come in the next day and get more and then walk out and feel fine? Or are you going to be sore after? Like how exactly does that work?
Yeah, thank you, Walker. It's a really important question. And so we are really hoping to learn some of the side effects that can happen. With any treatment, with any trial treatment, there is always a certain level of uncertainty or unknown. So we try to predict what some potential adverse events might be, and to the best of our ability, but I always am also prepared in a clinical trial for the unexpected. But what we can predict is, for example, the reason why we fractionate or split up our histotripsy treatments. One of the big reasons is I would like to reduce the risk of tumor lysis syndrome. So these tumors tend to be really large in volume when we see these patients. And so if we ablate too large of a volume of tumor, then we might create a situation where there is the inability for a patient physiologically to be able to cope with that degree of cell death that's caused by the histotripsy. And so that's one thing that we try to do, which is why we split up those treatments. So then related to your question directly of can they come in one day, receive treatment, and then come in another day. So we have tried different intervals of treatment. So for example, in some of our earlier studies, we had patients come in, get treatment one day, they come back the next week and get their second treatment. And currently we're in a phase of the study where we're exploring decreasing that time between treatments. So our patients now come in every 2 or 3 days between their treatments to receive the next treatment. To your question as to whether they can be more sore after, yes, that is something that we had anticipated, kind of based on the some of the reports from, say, people with metastatic bone tumors who may be getting HIFU treatment, so thermal HIFU, where there is a transient period of increased pain after the treatment, but then the treatment is intended to mitigate pain. And so eventually, after that transient rise in discomfort, which we most likely comes from the inflammation that is that's generated in histotripsy, we expect that patients have an increase in their comfort level. So in our dogs that we deliver the treatment to, I always speak to their families to tell them to expect that that their dog may be limping more and the area of the treatment gets more swollen because of the resultant inflammation. And then, but then over time, so typically within a few days after the final histotripsy treatment, we tend to then see resolution of that degree of pain. And so, so yes, we can see increased pain, but we expect it to be transient. And of course, we're learning more. So as we get more patients enrolled.
Yeah,
Uh,
that makes sense. Thank you.
Yeah, and I kind of related to that because I did want to ask about how quickly they would see that palliative effect. So it sounds like a few
Mhm.
days after
Yeah.
maybe initial swelling. What about just I'm trying to kind of get a better understanding of the kind of ideal tumor for this type of treatment. Is there kind of a min or max on the type of tumor? And also just in terms of positioning, I don't know if there are any limitations with the device of like how well you would be able to reach certain areas that might normally be unresectable with surgery.
Yes, thank you. That's a really good question. So, with regards to tumor volume, the smaller the tumor, the more it's more favorable for the patient because we are managing lower levels of cell death, for example, and also fewer treatments. So even though we can treat really large tumor volumes, we prefer it if our dogs don't have to undergo. So right now we're capping the limit for the number of treatments at 5 per dog. And so the repeated anesthesias, even though dogs can tolerate that, I want to also balance, what we're asking of our patients in terms of the need for anesthesia, and balance that against ablating their tumor. So at the current construct that we have, we limit it to 5 treatments. And so that inherently then limits the volume of tumor that we can accept into our trials. So I've certainly screened dogs where I've unfortunately had to inform their families that their dog's tumor is simply too big and it's not, we can't treat it within 5 treatments. And so in the future, perhaps if we can increase the efficiency of our treatments and be able to treat more volume in a shorter period of time, we could potentially think about increasing the amount of tumor volume that we can ablate. So that's down the road, but very much a goal of ours. And so then you had, sorry, I apologize. I'm blanking on the second part of your question. You asked about the tumor volume.
Oh, yes. And then also just if there are, just with the nature of the actual device, how well
Yes.
it can reach certain areas that normally would be unresectable with surgery.
Yes. Again, very excellent question. So we have definitely some device limitations right now. So we can treat a lot of different tumors in different portions of the appendicular skeleton. So we're also limiting our trials to the most common osteosarcoma tumor, which is the appendicular osteosarcoma tumor in the location, in terms of location. we can, with our histotripsy system, treat from mostly lateral kind of ablation. So from the outside, we can, if we can position the dog appropriately, we can treat medially. So coming in from the inside, we can position some of our dogs to be able to receive treatments medially, especially in the upper limb areas, in the humerus, in the femur. Those tend to be a little bit more challenging, and that is part of one of our goals for device development, is how can we increase the versatility of these devices so that we can we're able to treat hard to reach locations. As you saw, the Histotripsy setup is quite cumbersome, and especially needing that interface of water. And so the Histotripsy device development side, there is a lot of work that's going into making these devices smaller and therefore more versatile. And for example, with our oral tumor work, we are trying to evaluate Histotripsy devices that could be placed intraorally and try to ablate some intraoral structures that way. So it's in the development. It's very much a limitation that we can encounter at this time, but we hope to be able to overcome that with the current work that we're doing.
Great, thank you. I think Walker has another question from the audience. I know we're running a little late, but we definitely wanted to get to this question.
Yeah,
Yes.
there's a question from the Q&A. They ask, I'm interested to know how targeted it is possible to make the ablation. For example, if you had a tumor in a difficult location surrounded by organs, how constrained to the tumor can you make the treatment?
Great question. So at the moment with histotripsy, because of that differential threshold for the tissues that allow for specificity of the histotripsy ablation, we can very much tailor the ablation to only affect the tumor. Now, there is, I expect, as with any device, I wouldn't go as far as to say, oh, we can do it in every single anatomic location. There are going to be some limitations with how specific we can be in, say, for example, I know some of the work that may be carried out in different tumor types where there might be other vital organs that might be in the way of ablating, maybe some structure in the abdomen. And so we can encounter challenges where perhaps the organ that is quote unquote in the way might have a threshold that is very similar to what's needed to ablate the tumor, in which case it does create a challenge to create specificity of tumor ablation. Fortunately for us, specifically in the field of osteosarcoma ablation, at least with appendicular osteosarcomas, we don't tend to encounter that. The tissues that we encounter in the ablation zone, the tendons or even some vessels, potentially, they do not tend to share that ablation threshold. So as the one that's used for tumor ablation. So we are fortunate not to have that limitation so far, but I can certainly see limitations potentially arising when we start to get into more complicated locations. Say intrapelvic tumors, for example, could be potentially challenging, or spinal tumors might potentially be challenging as well. And those are certainly sites where osteosarcoma can arise as well. But I think that I have so much confidence in my bioengineering collaborators that I think that, presented with those challenges, they they will find a way to work through it and work through it well and thoroughly. So so that's a good question. I hope that answered it.
Yeah, that was perfect. Thank you.
Thank you.
Thanks so much, Dr. Tuohy, for this fantastic overview on Histotripsy. And it sounds like there's a lot more development. So we look forward to kind of hearing more as that progresses. Really appreciate your taking the time to join us on Osteobites today and for making it better for canine and pediatric osteosarcoma patients. More information on this and all Osteobites can be found on our website at mibagents.org, on the MIB Agents YouTube channel, and at your favorite podcast place. And we hope to see you next week on October 31st, which is Halloween. We are going to be joined by Dr. Shahana Mahajan, a professor and principal investigator from the Hunter College of the City University of New York. And she's also an Outsmarting Osteosarcoma 2024 grant recipient. She will provide an overview of her funded work on investigating ribosol as a possible treatment option for osteosarcoma. You can find our Osteobites lineup for the next few months on our website. And if you have any ideas for topics that you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you again, Dr. Tuohy and Walker, for joining us today. And thanks to all of you for spending an hour with us today. We hope to see you back here next week on the 31st when we chat with Dr. Mahajan. Thanks, everyone. Thanks, Dr. Tuohy. Thanks, Walker.